Panic disorders. Okay. Previously, we were on specific phobias and generalized anxiety disorders. Now we can jump over to the other oh so common and oh so frightening panic disorders. So, typically, this is just general discomfort. Okay, and there's a whole list of criteria or symptoms that are given in percentage. You can get on that on up to date. But the common signs are like tachycardia, sweating, you know, impending doom sense. Okay, you know, tachypnea, numbness and tingling in the hands and feet. And why would that be happening? Well, when we're here, wait one sec. When we are increasing our respiratory rate, we are going to be breathing off our CO2. Our CO2 goes down. CO2 has the charge that's causing our pH in our body. It's another thing that's helping with our pH. And when our CO2 goes down, we become alkalotic. Okay? And when we become alkalotic, our red blood cells have negative charges on them now. And, one of the common extracellular electrolytes that likes to bind to that is the trusty calcium. And then when calcium binds to that, ionized calcium is going to drop. When that drops, that leads to our membrane potentials in our muscles, typically around our mouth and our fingers. You start getting like these little twitchings. You'll get the twitching, and they think like it's something like they just think it's like the end of the world when that stuff starts happening. But that's typically the main thing that's happening when they start increasing their heart rate. All that fun stuff start happening. Now, typically in the past, they used to diagnose panic disorders with the agoraphobia and needing to describe that, but that no longer is needing that in the DSM-5 criteria. And now there is agoraphobia and panic disorders are now separate diagnoses. So you don't need to remember those as having two identical or mutual relationships. Another important thing that they can come back and get you with is the purpose of what and why are you having this type of, sympathomoletic type of response. And that goes back to, anatomy. We go locus, let's get this in red. Locus ceruleus. And if you don't remember that, that's where our neuroepinephrine's made. Neuroepinephrine is going to be causing our tachycardia, tachypnea, the feeling of that impending doom, the sweating. And then also these patients will have another problem in their parenchyma, decrease amygdala. If you remember amygdala, and that was where we associated fear with previous memories and all types of that. And then you can remember those patients and going back to what was that syndrome? Kenner-Foster or Kluver something, when they had no fear for anything, and then hypersexual. That could be kind of out of the scope for right now. But back to the panic attacks. Okay. So once again, you want to rule out these guys are doing drugs, so rule out substance abuse. Want to rule that out. Get that TSH done. And for this, you're going to get the UTOX. Okay. And that's probably going to be the first thing you want to do. Surprisingly, these patients also have higher risk. Write that in blue. Most patients with panic attacks are higher risk or have cardiac problems. So Like mitral valve prolapse is one. And most of this information I'm getting is from up to date, if anyone was suspicious of anything or having any type of anxiety from what I'm telling you. Also, these patients have a higher risk of having associated asthma. Now, once again, we can relate this back to how they could ask you this on step 1, mitral valve prolapse. Again, what are these patients most commonly, they're most commonly what? Associated with some connective tissue disorders, Marfan's, which is a problem with fibrillin. What else? Klinefelters. Oh, yeah. Here we're going all the way back. Klinefelters. Ehlers-Danlos syndrome. Okay. And this is going to have what type of sound? This is going to have a mid-systolic click. And that clicks due to what? Oh, it's the chorda tendineae. Yeah. And then this systolic click is going to be followed by that regurg flow. Regurg flow. So with these people, they're going to, with the ones with anxiety, you know, it's just going to make it even worse because anxiety is going to do what? It's going to increase heart rate. Heart rate is going to do what? Decrease preload. Decreasing preload is going to what? Decrease your diastolic filling. Decreasing diastolic filling going to decrease perfusion. So that's just some of the basic things in the back about that. Going back again to the panic disorders. So these guys have those increased risks of that, shortness of breath, and then an autonomic response. You got to rule out against substance abuse. And then also you want to start asking them if they have any other symptoms of depression. And why would you want to do that? Well, mixed. You got mixed depression with mixed features, excuse me, which is now on DSM-5, excuse me. And once again, for these patients, our treatment is going to be SSRIs. And if they gave you a list, I like to remember this as sick. I don't know why I remember it like that. So that's sertraline, citalopram, paroxetine, and fluoxetine. So your fluoxetine is going to have also GI. This one has high GI. Okay. This one's the fastest acting. So if they gave you a list and they wanted, you know, it was more of an acute setting, I would choose this one. Fastest acting. Okay. That would be the one I would choose. So, we did the panic disorders. What is another important thing we can go over? PTSD and acute stress. Just going to hit these out one by one. All right, so PTSD. What do you need to have PTSD? All right, PTSD, post-traumatic stress disorder. So you need to have something life-threatening or otherwise traumatic. Life-threatening. And this can be something that you heard from someone that you love that was close to you, something that you saw. It can't be anything you saw over media, though. Cannot over media. So like something you watched on TV. You can't have PTSD from watching Saw, okay? No, that's just called, just don't watch horror movies, or you don't like them, okay? Now this has to be greater than 1 month. 1 month, okay? Until then, it's going to be called an acute stress disorder. So less than 1 month, it's going to be acute stress disorder. In patients with acute post-traumatic stress disorder, let's write this in red for you, high incidence of substance abuse. Well, they're PTSD, yeah. So you're going to want to avoid what? Benzos. Avoid benzos. And once again, going back to the pathology, which has been commonly tested, they can come and show you a scan or give you a description of the patient and say, what do you expect to see on the CT image? Decreased hippocampal volume. And I'm not really sure why that is. So, well, here we go back again to the treatment. The treatment for this is going to be SSRIs first, followed by, at the same time with, conjunction's always better, CBT. You know, relaxation training, desensitization training. And these patients with their nightmares, they can get prazosin. And you guys remember what prazosin is, obviously. And this is for the nightmares. This is an alpha-1 receptor blocker. So these guys can become hypotensive, orthostatic. And they could give you a big scenario of a guy coming in on the 4th of July, or he's going, like, for veterans. What would most veterans actually be surprised? Don't like the 4th of July. And they're going to be spending their time in the basement with headphones on and isolated from everyone else because they don't want to hear the fireworks, because it just reminds them of what's happening. And you got to have at least two of the criteria for this, and I like to remember it as rant. So they need, so you got to, first they have to have a traumatic event. Okay, and they have to be reactive to that. So how we just explained, the guy with the fireworks, that's reactive. He's avoiding. He doesn't want to be around anyone. Avoiding. Negative alterations. Negative alterations can be a sprue of stuff saying that he doesn't want to remember the event. So a patient with PTSD can be just forgetful, not wanting to learn anything new, or having problems with cognition or attention, or also just doesn't remember anything of that event, having like retrograde or post-anterograde amnesia. And they're also, remember this, reactive to change. T, reactive to change. And you have to have at least two of these. Okay. And if you needed a refresher, this can be found on the usmlle step first aid book on page 396 and 397, the most recent version.